Before starting, I would like to welcome everyone who has joined us online, and I would like to welcome Dr. Xavier Falieres. Before he starts his talk, I would like to give a brief introduction of Dr. Xavier. Dr. Xavier was born on August 18, 1963 in France. He settled in the Netherlands in 93, where he is working as perioperative anesthesiologist since 2002 at the Albert Schweitzer Hospital, a major teaching hospital near Rotterdam. He's working full time as perioperative anesthesiologist and has been at the same time medical director of the operating rooms for between 2006 and 2018. Since 2013, he is the president of Dutch Society of Ambulatory Care. He represents the Netherlands at the International Association for Ambulatory Surgery and is the member of its executive committee. He was from 2009 until the beginning of the COVID pandemic. He was regularly presenting in Myanmar to teach at the four universities of medicine of the country. Since the recent political changes in Myanmar, he's very active within the network of friends and colleagues teaching online to young doctors who fled the dictatorship. The National Union Government of Myanmar, fighting to re-establish democracy, coordinates these teaching sessions. Xavier has two major passions, traveling and classic music. And I'm so grateful to him that he has accepted our invitation from the platform of Pakistan Society of Anesthesiologists to give a talk on ambulatory surgery. I welcome you, Dr. Xavier, and we are delighted to have you, and we are looking forward to have your talk. In the meantime, I would request the participants to kindly keep your cell phone muted. And Xavier, we also have a few participants who are from Myanmar. I hope they join us today as
Oh,
well. So
yeah.
if they will join, I will introduce you to them as well.
Okay. I think if they are anesthesiologists, I may know them. So we have almost 1 hour with the discussion. So we have time for a large overview about ambulatory surgery in high-risk patients. So if I may share my presentation, yes. Okay, can you see the lecture?
Yes, we can see that.
And okay, so thank you, Asma, for this very kind introduction. So we are going to speak about one of my favorite things, not only, but is ambulatory surgery in high-risk patients in ambulatory surgery. As you said, I live in the Netherlands, in the south part of the country, very well known for this diet with the windmills, the Kinderdijk. I know from Pakistan it's very difficult to get a Schengen visa, but we will have in May this year in Oslo the International Congress for Ambulatory Surgery, which will be a great moment. So I'm working there at Albert Schweitzer Hospital. We are a teaching non-university hospital. We are part of the University of Rotterdam, and we operate 25,000 patients a year. We have 14 rooms. We do 70% ambulatory, 20 short stay, and 10% long stay. We have reduced our beds from 1,000 to 500. We have a lot of chairs, and ambulatory department, it means 1.7 per bed and per day, and 2 patients per day and per chair each day. So we can begin the ambulatory with a statement. The sooner back home, the better the outcome. And this we know. It's better to send the patient as fast as possible back home. So we see that the number of patients operated in ambulatory is increasing. We have a migration of medically more complex patients. This we know everywhere in the world. We have a migration of more complex surgical procedures. We have also an improvement in the efficiency in daycare surgery. It's more and more efficient. And being efficient, we can operate more patients within the same cost, within the same time. And everywhere as a constant, we have a fear for ever increasing healthcare cost. So if we have a look here in the hospitals beds in the world per 1,000 inhabitants 2021, you see here that the mean is 3 or 4 beds. If we have a look at the length of stay, you will see that Japan, which has very, very, very conservative country, they have a very long length of stay, 14 days, compared to our country's 5 days. So, some facts. Patients, they are all getting older and sicker. We accept more and more patients with very high comorbidities. Before, it was, when I was a young anesthetist, it was a challenge, and now it's business as usual. The patient, is bad, and nothing to do about it. We accept it. Healthcare is also becoming very, very expensive, and all the hospitals everywhere in the world are under pressure because of the high cost. So number of beds is dropping dramatically. The length of stay is getting shorter and shorter, and we have everywhere a shortage in medical and paramedical staff. So a safe ambulatory surgery with high quality of care is one of the solutions to solve this difficult equation. It means that we are confronted every day with high-risk patient, high-risk surgery we would like to send back home the same day. So before, when ambulatory began in the 90s, it was only very, very simple operations in healthy patients. And now in the future, we are doing extensive procedures in as a 1, 2, 3, or 4. 70% of the surgical procedures could be now done in ambulatory, and within a few years, it could be more. And we have a lot of new surgical techniques, and it means that all lab collate, total hip, arthroplasty, knee arthroplasty, and it could be a very long list. Sorry. No, I'm busy. Ik ben bezig, sorry. Hoi. Ik doe mijn phone out, sorry. So we can do more and more, and we will have a look at the list what we're doing in a hospital, done in ambulatory, but it means a lot for us as anesthesiologists, also for the surgeon. And the big changes is that we need more and more ambulatory surgeons and ambulatory anesthesiologists. So the advantages of ambulatory surgery are patient-oriented. The patient recovers in a familiar environment, which is much better. We have less infection when we send the patient back home very fast. We have also less complications, as for instance, deep vein thrombosis. And we have an early return to daily life, less delirium, less post-operative cognitive dysfunction, and also less cost. So the topic of today is ambulatory surgery in high-risk patients. So we have perhaps to begin with the definition. What is an high-risk patient? Perhaps what I see as an high-risk patient for you say, no, it's not, or the other way around. So an high-risk can vary from a low-risk procedure in a high-risk patient to a high-risk procedure in a high-risk patient. We have all the scala of different scenarios. We have the structural parameters, national, in your country. Is ambulatory surgery already developed in your country? Before you say, okay, we are going to do ambulatory surgery, if you're not used to it, it won't go good for the patient. If you are doing it, do you have guidelines for your country? And then you have the regional aspects within a country. In which structure are you working? Which equipment do you have? Do you have trained doctors? Do you have trained nurses? Do you have 24 hours facilities? It will change a lot. If you don't have any facilities, okay, you can do some very easy surgery, but don't begin to do high complex surgery in ASF3 patients. The patient parameters. How do you select your patient for ambulatory surgery? Certainly in high-risk patient. So it means from a very simple hernia repair to a lobectomy, from a healthy patient to a patient with multiple comorbidities in ambulatory surgery, everything is possible. It depends on a lot of different parameters. So when you are not used to perform ambulatory surgery, you begin with minor surgery, you monitor, and then you will expand the indications. And I will show you how to do it. Yeah, you may use the ASS course, we'll come back on it, but then you begin to the easy ones, and then you will extend to the difficult patient. You start within your own existing facilities before creating your own unit. Then you have to discuss the case mix with other colleagues, other specialties, over the logistics possibilities. Do you need a specific operating room for your ambulatory? Are you mixing with other cases? How is your dedicated nursing staff or your operating room nurse staff for the ambulatory? When you all agree, you would try a model within your own possibilities. And then it's okay, you will try to build your own facility dedicated to ambulatory surgery. And what is very, very important to know, when you want to operate high-risk patient or performing high-risk surgery in ambulatory, do you have 20 hours facilities, or are you closing at 6 p.m., everybody's going home? It's very important, because in which structure are you working? Do you have protocols? Do you have 24 hours facility within the hospital, or you have to find an ambulance and transfer easily your patient to a 24 hours facility? What are the risk moments? Have they been evaluated? Is also very, very important. And we have some barriers, infrastructures. Defensive medicine. If something happened to my patient, we have seen Japan, they have a very, very long stay for patient 14 days because they have pure defensive medicine, for instance. What is the involvement of the nursing staff in the perioperative trajectory? It's very important. You need wonderful nurses. And the patient doesn't want, the patient wants to stay. It could be a problem. And another barrier, we'll come back on it, is if you have a medical specialist, for instance, a surgeon, who will say, I am the big boss, I'm going to decide everything. It doesn't work. So, some basis guidelines. When you are performing ambulatory and when you want to begin to do surgery in high-risk patient, you really need appropriate trained personnel. You have properly maintained equipment for appropriate care. You have all documentation of the care provided that required at other surgical sites. It means it's not because you are an ambulatory center that you have less equipment. You need also the basic equipment to perform safe anesthesia, safe surgery. You use the standard monitoring according, for instance, to the American Society of Anesthesia Policies or guidelines. You have a post-anesthesia care unit or recovery area with trained nurses with enough equipment, and you have specific discharge instructions. So you have also all the emergency equipment. If you're doing high-risk patient, it can go totally wrong. So you need everything. You have a written plan for emergency transport of patient when something happens. You know what you have to do. You're trained, you have everything on paper, and you have a protocol. You have also maintenance and documentation of a quality assurance program. You have a continued education for the physicians and other personnel. and the safety standards cannot be jeopardized for patient convenience or cost saving. That's also very important. We know that we have to be cheaper and cheaper. We have to do a lot for less money, but it never can be that it will be cost the life of the patient. So patient selection, you have the very fit and the very obese. They are the two extreme patients we have, but the patient selection is multidisciplinary process with agreed protocols for patient assessment with inclusion and exclusion criteria for day surgery. And the most important of the exclusion criteria, not the inclusion one, is which category patient don't you want to operate in ambulatory? But the patient assessment for day surgery is also not only the medical ones, but also the social and the surgical ones. So the underlying medical disease should not be considered as sole criteria, but also the surgical procedure, the experience and the expertise of the perioperative setting, and the social aspects. So how will you select your patients? You have the comorbidities, this we know, we will speak about it. The social isolation, which is in our countries more and more a problem, people alone, living alone without contact with the rest of the world. The distance from hospital in time can be also a problem if the patient has to be back in emergency to the hospital. The patient and the family level of education, it can be very important to understand we have a problem, we have to go back to the hospital. The post-operative pain can be also very challenging. Don't send back a patient with a lot of pain. It's crazy. Then the patient will be back some hours later at the hospital. The GP has also a role to play in the post-operative phase of this patient. But one colleague, GP, told me, I am not your recovery room. It means if you send the patient back, it's not that the GP has to be phoned some hours later because it's not going good. Do we have an ambulance? Patient information, preoperative assessment, we speak about it, give information flyers to your patient, but very simple. And then informed consent, orally of written. It depends on each country how you deliver informed consent to your patient. And then I will insist, we are very focused since so many years now on the pre-habilitation, certainly in high-risk patients. When we have time, we try to optimize the health condition without delaying the surgery. And when it's not possible, some cancer surgery, we don't have time, but we do short programs to try to prepare our patients for surgery. You will tell me, yeah, we don't have so many evidence in the literature, but we are busy with studies and we see that it works. So really, I would say, please try to focus on pre-habilitation in high-risk surgery, high-risk patient. So I want to come back on the American Society Anesthesia score, the ASA scores we all use in the world. They are not really the most reliable criteria for ambulatory surgery. Why? Perhaps you know Beverly Phillips. She's a past president of the American Society of Anesthesia. She is also, as myself, an executive committee of the IAS. The ASA scores have been done for the US insurances, because they are doing a lot of outpatient in some not very safe conditions. That's why now they are very, very strict. It means we have more and more ASA 3 and 4. So when you have a look at the last definition, 2020, ASA 3, if you have had a myocardial infarct, a severe of your stents, of a transient ischemic accident, it means someone with a stent running a marathon is theoretically ASA3. So that's why be careful when you are using the ASA scores. Yeah, it's not so reliable, so be very careful with it. So this we know, it's in EU, but all the world population is getting older and older. But the age is not a contraindication for their surgery. Elderly, they are high-risk patients. But please, when you have 5 minutes at the preoperative evaluation, try to use a modified Frailty Index. MMEC, it takes too long time, but a mini cog with 3 words and a clock drawing, it's 5 minutes to have an idea of the cognitive functions of your patient. And you can make the patient selection very complicated, or you can choose also the keep it stupid and simple and stupid method for exclusion criteria. We are performing ambulatory surgery already 30 years. So we are very far, and we have now very simple exclusion criteria for anesthesia. We have the potentially life-threatening chronic disease, really the bad patient, or the patient with severe OSA. We have the morbid obesity with a BMI above 45 with comorbidities. Without comorbidities, we don't care. If they fit the table, they can be operated. Then in all the country, we have a rule: the children post-conceptual age of 60 weeks may not be operated in ambulatory surgery. Then you have the time to be back in hospital in case of complication, and the home situation, the very, very important role of the intake nurse. These are, yeah, it's a very dynamic, it changes almost every year. This is some surgery we are performing every day in ambulatory. Yeah, we are doing a lot. Mastectomy, sorry for the typo. You see here, okay. We do a lot of surgery in ambulatory. But what is very important is the ambulatory surgery anesthesiologist and the ambulatory surgery surgeon. We need more and more anesthetists and more surgeons who like to do it. We have to find it wonderful to perform ambulatory surgery. We know when we are working in some centers with surgeons or nurses or anesthetists not interested in ambulatory surgery, it will lead to overnight stay. So when you are doing it, certainly in a high-risk patient, you have really to know what you're doing. And we need an anesthetist. We are everywhere implicated in all the ambulatory surgery process, and I will say in all the OT process. The surgeon is there to operate. Wonderful, the anesthetist. We have an overview of everything, what's happening in the OT. So you see here in the chain of the healthcare of the patient that you need an anesthetist almost everywhere, from the pre-assessment to the discharge home. This is the ideal perioperative patient flow. That's for the one very interested in the very details flow of the patient, but you will see once again that you need the anesthetist everywhere. So the preoperative assessment, we have to do it. It's a communication between anesthesiologist, surgeon, and primary care physician. Very important. We are there to resolve medical problems prior to surgery. We have some questionnaires, and we decide now we are doing less and less patient coming at the ambulatories, at the consultation. We do a lot of telephone interviews. We decide, but 70% are not coming anymore. So we need also preoperative assessment to avoid delays in cancellation. It's efficienter. We start the education of the patient at the preoperative screening, and we also review all the medication, and sometimes we discover what's not going good. So we discover a lot of problems, and we try to solve all the problems at the preoperative screening. And the preoperative testing, please only do what you need to do. It's not the place to screen for what you perhaps would like to discover or for asymptomatic disease. You target on the patient history and you try to have protocols about it. It will save a lot of money. For instance, for us, under the 70 years old easy surgery, we do nothing. So we do only HB, HT, platelet, natrium, kalium, creatinine, glomerular filtration, and glycemia for above the 70 years old, and or some medication or some history. For a diabetes patient, HbA1c, the blood group and antibody screening only on indication. Chest X-rays is very exceptional. And when we need only, we ask other specialties. But when you ask other specialty, it means that you will do something with their report. If you only want the cardiologist to give you an advice about the patient, yeah, it will change your way of thinking of your anesthetist. If not, don't do it. But we see actually in the NR in the Netherlands, 20% of the screening are on paper, 50% on the phone, 30% are physically present. We have a good train. We have a lot of doctor's assistants that are trained to select the patients. And we see now artificial intelligence arriving, and it will select the patients. So anesthesia in daycare is very important to know. We are going to speak a little bit about anesthesia, certainly in high-risk patients. I would tell you, please, when you're going GA in ambulatory surgery, please do multimodal low opioids or do opioid-free anesthesia. All the blocks can be done with or without combined with GA of sedation, and spinal anesthesia, we are going to speak about it. So multimodal approach anesthesia, I would tell you in ambulatory, please use as less as possible opioids, use dexamethasone, high doses, 12 milligram, use magnesium, Lido IV, ketamine, clonidine, dexmedetomidine, paracetamol, give on time the paracetamol, use NSAIDs, use local infiltration by surgeons. You have to educate the surgeon to give local infiltration. And please anticipate PONV with androstenedione of granisetron. Inhalation anesthesia technique, it works wonderfully good. It's also my preferred way to give anesthesia in ambulatory surgery. We can speak about the Desvuran. Desvuran is wonderful, was wonderful, but Gary Shioshi, also from the executive committee of the IS, didn't find any difference already in 2001 between Desvuran and sevoflurane with respect to home readiness. But please, in this time of global warming, inhalation anesthesia is only if you can work with ultra low flow. We are accused by Baxter to do Desvuran bashing in our country. Desvuran disappeared. Now we won't use Desvuran anymore. 1 hour of surgery using Desvuran is 200 to 400 kilometers driving a car. So, and the nerve blocks. The nerve blocks is wonderful because you can avoid the GA. You can do a lot, up to very complex surgery. And certainly in high-risk patients, when you don't want to give GA, you will prefer blocks. When it's possible, then don't need opioids. you have a shorter PACU time, or perhaps no, you can bypass the PACU. You will lower the postoperative complication rate, and you will have the patient very fast back home. Some negative aspects of the blocks, it can impair early mobilization when it's necessary. Patient feedback, we are busy with a very huge study here. They don't like very long blocks, and anxiety when they have to wait hours and hours before to have the muscle and the sensitivity back. Yeah, they don't like it. Rebound pain is a major problem after blocks. We are almost finished with our study about the rebound pain, but we see that the patient after a block may have much more pain than under GA. We are using a lot of adjuvants in our blocks. Sometimes we try to work with short working proximal blocks and long working distal blocks. But the GA with multimodal approach anesthesia, local infiltration, and post-op opioids limited is also an option. It can impair early discharge, but not the same day discharge. So some people more and more are trying to tell us, please avoid local regional anesthesia in ambulatory, do GA, give opioids, and send the patient back home. I will go very fast about the Wallen technique. I don't know if you're used to it. It can be very interesting in high risk patient. And we are performing it more and more, the surgeon, because they don't need anesthesia when you are performing a Wallen. It's a wide awake local anesthesia, no tourniquet. It means that they will use a very important quantity of local anesthetic mixed with adrenaline and bicarbonate at 20 to 50, sometimes 100 milliliter. It means after 20 minutes that you can operate up to 3 or 4 hours. You don't really need an anesthetist, and you can do foot surgery, hand surgery under Wallen. So back to the spinal anesthesia, because we are in high-risk patient and ambulatory spinal anesthesia, I can tell you our nurses, they hate it. They really don't like spinal anesthesia, or only in the morning. So for a fast patient discharge with minimal side effect, the ideal anesthetic for short duration should be the minimal effect on hemodynamic, rapid onset, deep surgical block, minimal effect on urinary retention, and the minimal risk of TNS. Yeah, difficult equation. So Lido, it has been the choice for many years, but TNS is a major issue with lidocaine in spinal, so now we don't use it anymore. The bupivacaine, low-dose hyperbaric, yeah, it works, but we still have a lot of urinary retention problems with delay in the discharge of the patient. The prialocaine, now we couldn't say it's better than the bupivacaine. It shows a more rapid recovery and return to the bladder function, but yeah, it's not really a wonder something. The chloroprocaine is wonderful, but it's very short. It means you don't have time for a student or for a trainee learning to operate. The articaine is something wonderful. Articaine is the Lido without the TNS, and a little bit the prilocaine and the chloroprocaine. All the qualities we would like. It's only off-label in a lot of countries, but it's widely used. So if you choose for a spinal anesthesia in ambulatory surgery, articaine could be the choice. And then you need wonderful nurses. Certainly, if you are performing high-risk patient, high-risk procedure in ambulatory, how many specialty do you have in your ambulatory surgery unit? It depends how many you have: ENT, general surgery, trauma, eye surgery, everything. So you need perhaps multi-skilled, or specialties, or specialized in some domain within ambulatory surgery. We have multi-skilled nurses. And then the skills of the wards, nurses, both general ward and PACU, efficient, with limited competencies of separate general ward and PACU. That's what we have. We have specific PACU trained nurses. They're more expensive, but they can perform much better work, much safer work, certainly for high-risk patients. And the very important person and all the ambulatory process, and certainly in difficult cases, is the intake nurse. She is playing a wonderful primary role. She is the first point of contact for the patient in hospital or the clinic. She will review patient injuries. She will take the vital signs. She will place them in the appropriate order for treatment. And she will review the patient's social conditions, which is very important because as anesthetists, we don't have the time to do that. So within minutes, a good intake nurse, she will ensure that patient will receive safe and responsible care with the highest quality care. And now I would like to go on. Perhaps I'm seeing at the time we have, yeah, 10 more minutes. I will go in the high-risk patient, the focus factory. It's very important to know when you're performing ambulatory surgery, you have to do it very, very systematically. And I will take the example of Ford, the cars, which are very well known. It has been one of the top 5 produced cars in the world. And you see what very important, what Henry Ford said: any customer can have a car painted any color that he wants, so long as it is black. It means there are no so many ways to do it very systematically with high quality. So we have to standardize all the process in ambulatory to have the best quality, and standardizing upward is very important. And don't forget, what you're doing is perhaps today's best, but it's not the best for perhaps tomorrow. So you have to always to think about what you're doing. Is it good? What can I improve? And then you try it and you standardize it. And certainly in high-risk patients, you have to standardize all the procedures to work safely with high quality of care. So we analyze our operation results. We have quality indicators. We are going to speak about it. We analyze all the results. We find the common denominator. We try to differentiate between subgroups of patients. We make some categories of risks, and then we try in a clinical setting, and then we try in a clinical setting as care surgery, and when it's okay, we do it in ambulatory. So, as I said, it's a multidisciplinary something. We need dedicated teams. We have in and certainly exclusion criteria, and we are looking at the 3 main categories for our patients: social, medical, and surgical. Okay, this I will go on. So the more realistic expectations can be obtained by patient education. That's very important, to try to educate our patient. Information for patients, what to expect, improve their coping abilities, resulting in a perceived better control of participation in the care and psychological distress. They are in the big stress patient at your consultation before the surgery. And when you do it, you will see that you will get a better adherence to the therapy, and you will reduce the postoperative anxiety and less pain. So it's not easy, and we are a part of this very high difficulty to try to have a focus factory as production of cars, because we are doctors and we everybody knows best what he has to do. So nobody is boss. We do it together. The staff and the physicians, they have to understand there is a gap between the current operation and the ideal. It's not the same. So we have to share process and outcome measurement in open, objective, and clear matter. We have to speak about what we have done and the results. We have to redirect from finding faults to finding solutions. Don't think about fault, think about solutions. So identify reduce waste in workflow. You have the Toyota production system, for instance. So we need standard procedures, certainly in high-risk patients. As anesthesiologists, we need protocol-based anesthesia. I can tell you in my unit here, we have protocol-based anesthesia. And for some procedures, is only one anesthesia possible. For the bariatric surgery, we do a lot of bariatric surgery in ambulatory. We have one way to give anesthesia for everyone, the same. And we have dedicated teams. So it's very different to run efficiently operating in daycare and operating an efficient daycare. That's very, it's not really the same. It's not only the way of thinking, it's the way of running a business. When you are doing ambulatory surgery, you are running a business with the highest quality. You have to improve the quality and reduce cost. Multidisciplinary, standardize upwards, and constant attention and readjustment when needed. It's a focus mindset. So I will go, when you are doing ambulatory, you need to measure what we are doing. So the IAS, we have quality indicators. You can use, you can find them on our site. But the most important you need to know is about the outcome and the unplanned overnight, the reintervention within 24 hours and within 7 days, the reintervention and unplanned readmission within 1 month, and the 30-day mortality. When it goes wrong, when you have too much unplanned admission, return to hospital, it means you have a big problem within your unit. It means you have to analyze it and to find where is your problem. Structural problem, medical specialist problem, nurse problem, direction, management, you have to find it. So, and there's also to be safe, you have to measure the postoperative bleeding, unplanned transfusion, cardiopulmonary arrest, thromboembolic accident, uncontrolled pain within 2 hours and 24 hours. Also the force in service, surgical site infection, the SSI, and postoperative sepsis. Very important, the 30-day mortality for all elective surgical procedure. We know from these very big studies from the Lancet 2011 that based on 1.8 million deaths after the age of 65, 32% within the year, 18% within the month, of 8% within the week before dying had undergone surgery. And we know certainly we are performing surgery in ambulatory that the outcome is much better. And what we don't speak so much about is from being independent before surgery, being to dependent after surgery. We have aging population. I'm back to the modified frailty index. to the mini-cog, evaluation of the cognitive function of your patient. And think about it. What is the impact of the surgery and anesthesia on your patient? Before intervention, you have this old lady, wonderful. After in the intervention, she is in a chair and she is dependent. So, and we know certainly that ambulatory improves the outcome of the patients. So all these indicators are wonderful, but you have to use it between hospitals and you have to use benchmarks. And the establishment of acceptable standards must be a concerted decision at the national level. And once again, the evaluation is not only the outcome of surviving, or it's also the quality of life after surgery. And you have very important programs using the PROMs and the patient-related outcome procedures, which are very important to be considered for the outcome of your patient. So it means within few years, I think we will do 80% of all the procedure under in ambulatory, but it doesn't mean that it means that your patient doesn't need to be readmitted after some hours, that the big hospital savings for the hospital, but they have to be invested in primary care. And we are the medical specialists, we have to ensure cooperation with all the structures and training for primary care. So the sooner back home, the better the outcome, yes, but you have to do it good. And to finish, pushing the limits, what happened recently after COVID, or perhaps with COVID, we have to work another way. We have learned a lot of COVID. We have a task reallocation. We have sedation specialists. We have a lot of physician assistants giving a spinal anesthesia, giving easy blocks. We have nurse practitioners. The sedation specialist, it's a huge shift. They are doing a lot what we are doing before under general anesthesia. They do it under sedation. Also, they are now learning to give blocks, to give spinal. So I think within 3 or 4 years, anesthetists will do only the high-risk cases. So high-risk patient ambulatory, everything is possible. You have to standardize the procedure. You have to be very conscious of what you're doing. And each country hospital may determine their own limits, establishing national and local guidelines according to healthcare system and laws. If your country doesn't allow doing ambulatory, you have first to change the law before beginning. This we have, for instance, in Czech Republic. They don't perform any ambulatory. They have first to change the law and then they will implement it. But it has to be safe, responsible, with high quality, multidisciplinary and protocol. So, and also you have to use quality indicator to measure the process in the entirety. So don't forget today's best, which surpasses yesterday's, will be surpassed by tomorrow's best. Thank you so much. I think I'm on time. I have 50 minutes. So, thank you.
Thank you so very much, Dr. Xavier. It was such a nice talk. And
it was a lot, sorry.
Where is the snow?
Outside. Yeah, I'm inside.
Yeah, I would love to see that. So before asking and before opening the forum for the question from the participants, let me share with you two of the things which you had just mentioned in your presentation or the talk. Sure. One is that articaine is not available in Pakistan. We don't use articaine, but we do have at some centers, we also have ropivacaine. At the same time, bupivacaine is also available. And you also mentioned that in the high-risk patients, 7.5 milligram bupivacaine may cause urinary retention afterwards. What is your comment on, or what is your thought on using 5 milligram of bupivacaine in high-risk patients?
I don't believe here. We have what we are we have a name of the rapid mix. So we
All
are doing,
right.
yeah. We are mixing, and we do it also for the total hip, total knee, because they have to walk to get out of bed 3 hours after surgery, and then they have to go back home. So we are mixing 2 ml bupi heavy 0.5, 1 ml is 5 mic sufentanil, and 2 milliliter normal saline. And we give 3 to 4 ml of the mix. So it makes,
Intrathecally.
yeah.
Okay.
It's our
And
rapid
what
mix.
are the
We are
results of
very, we
that?
are very happy with it.
Oh, okay. And there is no residual blockage or the urinary retention afterwards, which is one
Less,
of the
less. I would
which
say,
is one of the cause for the delayed stay in the ambulatory care.
I would say not never, because a colleague anesthetist, I gave her this spinal mix, and yeah.
So it is quite
It has been
possible that
difficult.
while mixing it 7.5 milligram concentration, it decreases down to like
Yeah. Sure. 5 to
5 or lesser.
7.5,
Yeah.
you have less problem. But I
All
would never
right.
say you have no problem. You have less problems.
Less problem. And we have other centers as well, like there are centers or the institutes who are larger and they have separate ambulatory care services, but there are other hospitals or the institute, as you have also visited Ziauddin. It's not a bigger hospital, but it's like, middle career hospital. And we have the ambulatory care services, but within the main operating room, like, we cater those patients, even the ambulatory care anesthesia patients in the main operating room. So we have the rest of the facilities similar to the for especially for the high risk patients undergoing the ambulatory care. They have the similar kind of post-operative care, the PACU care, the nursing care as the other patients would have. So you can say it's one of the benefits of working at a
Yeah.
relatively smaller setup, but at the same time, we don't have a separate ambulatory care. So now I would like to have the comments from the participants. If you have any question, kindly share or raise your hand.
I see a lot arriving on the chat. From Ireland.
So we
The
have one
ultra low
question.
flow anesthesia. What do you mean by ultra low flow anesthesia? 0.5 liters.
Yeah.
Under the 1 liter. Fresh gas.
And how low are we
From
talking
Mohammed.
about? And can we use done using a standard workstation, or only very modern machines are capable? Okay, so Dr. Xavier, there is another question with this. Standard workstation, I think you know why I think why he has asked this question, because some of the participants who regularly attend, I know that they are working at some of the distant areas in Pakistan, like not in the major cities but in
Yeah.
the distant areas
Yeah.
where there are, the machines are old
Yeah.
fashioned, and they're still using the manle kind of workstation, or the working station, or the anesthesia machine are being used, where they cannot use a
Low
low
flow.
flow
Yeah,
anesthesia.
this I
Yeah.
know.
So
But
yeah.
we do a lot of ENT kits here, and we still perform adenotensectomy without tube. It means we're working full gas, full open. So we are not doing good every morning from 8 to 10 a.m. We know. So when you can use low flow, please use low flow as much as you can. But I'm very conscious in the remote area of Pakistan or India or everywhere in the world, in developing countries, it's very difficult to work with low flow. I'm very conscious about it. And then I would say, then you have really to avoid this run.
Okay, so we have a hand raised from Dr. Azhar Rahman. Can you please unmute yourself and ask the question?
Hello, good evening, Xavier. Thanks for such an insightful talk. In 2017, I got the opportunity to interact with you when we conducted academic workshop at the Sound Guided Regional Anesthesia. That was a wonderful experience that I had. One of the anyhow, I have first of all, I would like to share my experience which we do. I actually practice in Aga Khan Hospital. We use low dose bupivacaine for anorectal surgeries, and usually we use a dose of 5 milligram or less than that. It's almost 1 ml, and that is quite effective. Most of the patients, they don't have motor block, and discharge from the post anesthesia care unit is very ideal. And most of the patients, they don't have urinary retention as well. My first question is for high risk ambulatory anesthesia. Is it different from the enhanced recovery after surgery program? Because most of the attributes they look similar in high risk ambulatory anesthesia as well. And my second question is, what about the post-op pain, which you experience in your setup? How many patients come back to the ER or readmission with pain? I'm sure you must have done some audits as well. Thank you.
Yeah, about the readmission because of pain, we have been very surprised with our recent study on local regional anesthesia, how many patients didn't need to go to the GP or back to the emergency. We did not know about it. So we will know much more after our study, but it's much more than what we thought. So it's a really alarming problem. Certainly after regional anesthesia, the rebound pain, not the readmission, but patient having to go back to the emergency and then they go back home. It's also patient education. And your first question about the PACU and the pain, what we're doing about the pain, postoperative pain, we go on using low dose opioids, and we try to use clonidine and other non-opioids medicines. And yeah, it works. But perhaps you could repeat, because it was the sound was not very good. The second question is okay, but the first question, please, again. Hello?
My first question was that when I see the most of the attributes of high-risk ambulatory anesthesia, they look a little bit similar to the enhanced recovery after surgery program.
It's the same.
So what is the difference between the two?
Yeah. Yeah. Not easy to answer. What can you give me an example, please? Because it's not so different from an inpatient.
To my understanding, enhanced recovery anesthesia is something to do with those kind of surgeries where, such as hemicolectomies or extensive surgeries, but needing earlier recovery, lesser stay, and to make everything fasten up so that patient gets discharged within a day. Or on the same day even. But for ambulatory anesthesia, to my understanding, I'm not sure because I haven't read it recently, and you are the best expert in that, so you might be able to comment on that, have a comment on it. That ambulatory surgery has mainly to deal with the surgeries in which the patients, they get discharged on the same day, within the same day, having no admissions inside the hospital, whatever the time duration.
Okay. That's why I said when you're doing high-risk surgery, high-risk patient, you have 24 hours facility, because it's much better. When it goes wrong, when it's too late, you keep the patient for the night. But back to the ERAS protocol, what we have done with the hemicolectomy right, for instance, which is the best example, before they were staying 1 week, and then we began the ERAS, and then they were staying for 2 days. And then we saw, after all, why do they have to stay for 1 or 2 nights? They can go back home. But it's very important to know when you are doing this high-risk surgery, high-risk patient, it's better to have a backup bed in the hospital. Don't do that in an isolated ambulatory unit.
That's right. So I hope that has answered your question, Dr. Azhar. And now we have actually we have a hand raised from Latif Shah. Can you please unmute yourself, Dr. Latif? Dr. Latif Shah, can you please unmute yourself and ask the question from Dr. Xavier? Okay, in the meanwhile, we can take another question in the chat box in which someone has asked about the Valent technique. For ambulatory surgeries is best to apply this technique, and could you give brief explanation about the technique?
If topic you can ask, a Pakistani graduate get to clinical attachment in anesthesia in the Netherlands. I something totally separated about a Pakistani graduate get a clinical attachment in anesthesia in the Netherlands. I had this. You have to speak Dutch. It's the big conditions. Can TIVA be used if SEVO or DES? Yeah, sure. I have, yeah, Dr. Salma, I have the question here. Asma, I see the question here on the chat.
Yes.
Sure.
Can TIVA be used if SIVO or desflurane
Yeah,
is not
sure,
available?
sure. I have some colleagues, they work only TCI, only TIVA, only.
And there is another question above it about the Valent technique.
Yeah. I was doing about the SIVO, the DES. If you want to use, you have to do it low flow. If you don't use it, please use total intravenous anesthesia for sure. It's not my preference in ambulatory, but I have colleagues doing it every day. If you ask the nurse anesthetist, they say we prefer SIVO.
All right.
Yeah.
Let me check if we have other questions.
About the
No, I
Wallen technique, ambulatory surgery is better, but all the hand surgery can be done on the Wallen. Also, small trauma of the worst, what it can be done on the Wallen.
So is there any explanation of the technique of Valent?
Yeah, you are giving a lot of local anesthetic with adrenaline and bicarbonate because less pain, and then you wait 20 minutes and it will bleed much less and you can operate a lot. So it can be very interesting in super high risk patient with a contraindication for a regional anesthesia, if you can give any local anesthesia, or yeah, it works. But will it be the future? Perhaps. I had at my own congress, the Dutch Congress of Ambulatory, a surgeon who spoke about it. He's doing almost all the hand surgery under warrant.
All right, that's great to know. I think we don't have any more questions. I would, before concluding, can I ask Latif Shah again if he's still there because his hand is still raised?
Yeah. I have to jump then to another meeting.
I know, I understand. Not to waste further time, I would request our president, Pakistan Society of Anesthesiology, Karachi,
he's there.
Dr. Xavier.
Yeah. We see.
To please have last comment.
Thank you very much, Dr. Xavier. It was very concise and to the point, and one of the best lectures.
I'm sorry, there is a connection problem. I left raised my hand, and there became a connection problem. I have two small questions, sir.
Yeah.
First of all, what's the role of TIVA in daycare, this ambulatory surgery?
The role of?
And second, TIVA, total intravenous anesthesia.
Yeah.
I was about to comment on that,
It's a sort of the same as
second question is that we are using too many drugs there. There is a problem of preservative free and with preservative. So what are the limitations of using these drugs? So these are my two small questions, sir.
Okay. The first about the total intravenous anesthesia. I use it, and certainly in oncology, we are here breast cancer center, so we operate a lot of breast cancer in ambulatory. It's only for me, this I use only propofol Tiva. For the other surgery, not oncology, I'm more for the SIVO because I like it more. But I won't tell you, you have to use Tiva or you have to use SIVO. I only say if you use SIVO, please think about the climate, about the planet, try to work low flow. But Tiva is wonderful. And if you have a bispectral index, much better. Okay. And your second question was about the conservative free.
Yes, sir. Yes, sir. It was about.
For the spinal anesthesia, you mean?
Yes, for spinal.
Yeah. Yeah, in principle, you may not use it. It can be very toxic. Especially if you try to use morphine intrathecally, morphine, you have really to use it without any toxic thing inside. I know it's a very big problem in all the, countries on this side of the world, but it's toxic.
So
You
I'm
were
really
thinking
grateful. Thank you so much.
can you give me an example of the drug you would like to use in spinal? With conservative?
In spinal, some people use magnesium.
Yeah. Yeah.
And
I know people using
opiates.
also ketamine, but ketamine with conservative is dangerous.
Yeah, ketamine, they don't frequently use, but this magnesium and opiates
Dexmedetomidine can
frequently
also.
The
Dexmedetomidine can be
dexmedetomidine is
used.
okay. The
Yes,
dexmed,
yes,
I
dexmed,
use
opiates,
it.
yeah, dexmed is
and
really
this
okay.
magnesium.
But dexmed in ambulatory,
Yes.
it won't be easy.
Well,
But
All right. So with
magnesium
this,
is
we
common, most common is
can
magnesium.
yes. I think Dr. Xavier has to join another meeting. So I'm
Yeah,
really grateful to you,
meeting.
Dr. Xavier. And before we conclude, we have Dr. Shabir. I'm really thankful to each and every participant for joining us every alternate week on this forum for the PSA online lecture series. And over to you, Dr. Shabir, for the.
thank you very much, Dr. Asma. Thank you very much. And thank you very much, Dr. Xavier. It was an amazing session, and one of the best lectures probably of this season.
Oh.
And our most junior speakers, they would know how to make a concise and precise lecture in a limited time, And I would share my experience as far as ambulatory anesthesia is concerned, and that is, I would really be hesitant, in our circumstances, to go for an ambulatory anesthesia in a primary care center or a clinic. My choice would be a tertiary care center in given circumstances. And again, I would be very hesitant to anesthetize a patient for ambulatory anesthesia if a relative contraindication, if I go through a relative contraindication, and I would still go for TIVA or minimal invasive anesthesia rather than any invasive technique like spinal or thing, I'm very comfortable with TIVA, using propofol or even Dex,
Yeah, sure.
I'm very happy as far as my ambulatory anesthesia is concerned.
Once again,
Thank
it
you very
was more to say don't use TIVA, total intravenous anesthesia. I wanted to say when you are using SIVO or Desflurane, please don't use Desflurane. And when you're using SIVO, which is wonderful for ambulatory, please
No doubt about
use
it.
low flow. And if not,
Yes.
please, if you have total intravenous anesthesia with propofol, please do it.
Yes, that's what I do. Thank you very much.
It's not my own taste. That's it. Okay. That's
Thank you, Dr. Xavier. Thank you, Dr. Shabir. And thank you, everyone, for joining us. I'm really grateful to each one of you, and especially Dr. Xavier for taking time for us and giving us such a good and insightful talk. We definitely would like to have you again in our next season.
Definitely.
And yeah, we can do next time something about my second big thing is local regional anesthesia. So
Yes,
thank
I
Oh,
know that because you
that
were
will
the
be
one.
wonderful. That would be
Yes,
lovely.
for the other participants who don't know, Dr. Xavier came to Pakistan, I think
Yeah.
just before COVID, I think
Yeah, just before
2018.
COVID.
Yes, yes,
And we did
I
a
remember.
cadaveric ultrasound guided regional anesthesia workshop, and it was a hit among
It
our
was.
colleagues. And yes, it was a big hit. So we would definitely would like to have you back again in
I would do.
Pakistan, inshallah,
Sure.
sometime soon. So let's see,
We
and
would love
good
to
luck.
have you with us.
So, and I
We
will
would
be
really love to
in March at
have you with us.
in Singapore for the WCA Congress.
Right. All
Okay.
right. That's great.
Thank
Okay.
you.
Take care. Thank you,
Hey,
everyone. Thank you.
Thank you.
bye.
Bye.
Bye. Bye.
Bye.
Bye.
Bye. Take care.
Thank you.
Have a good night from us
Have a
and
good
good
night.
evening to
Thank
you. Yeah.
you. Bye bye.